Howdy, y'all. Thank you for coming out. I really appreciate it. I used to live in Austin a little while ago, and I drove back up today from Houston. And once again, I lived in Austin on I-35 for about half an hour. So it's nice to be back home. I have two things I want to say before I get into my speech. The first is the most important. It took an entire army of people to put this book together. My partner, my father, my mentor, some advisors, etc. And one of them is here right now, and it's her birthday. So I want to say thank you very much to my best friend, Krista Casey Ziegler, for making this book happen. The second one is a piece of news that comes to us from, well, health policy news, which is a little bit less bleak than the normal news. It comes to us from a place called Quebec in Canada. Now, as far as I'm aware, Quebec is known for two things. One, it's punishing and deeply problematic black metal music. And two, its low measles vaccination rate. Right now, the vaccination rate for measles in Quebec hovers around 75%. Now, for context, you want to have 95% for herd immunity. So, Quebec had a measles outbreak in 2011. They're having a measles outbreak right now. Things aren't great. And they want to stop this. So, there are two kinds of folks that don't vaccinate their kids. On one hand, you have a small number of hardline anti-vaxxers, those who know that vaccines are chemtrails for your body and who refuse to let their children become vaccinated. But that's not all of them. Most folks kind of fall in the squishy middle, the vaccine skeptical. They Google vaccines good or bad and read the results, or watch TV, or look at the internet and go, oh, I don't know if this is harmful for my child or not. So they defer their choice, their demur, and as a result, tend not to vaccinate their kids. And those are the folks Quebec thought you could reach. Except doctors weren't reaching them. Doctors have a pretty short amount of time per patient. Doctors perceive themselves as being very rational and hate dealing with squishy, irrational patients. And doctors, frankly, can be pretty brusque, or brusque, depending on how you want to say that word. So they weren't getting the job done. So Quebec turned to social workers. And Quebec hired 53 vaccination counselors. These are folks who would walk into the neonatal unit when someone was born and say, hello, my name is Jean-Claude, because they're Quebecois. And, are you thinking of vaccinating your kid? Here's some charts, here's some graphs. Ultimately, this is your choice to make. I respect your agency, but please think about all these things as you decide whether or not to do this. And vaccination rates in the hospital observed went from 73% to 87%. This is massive. Someone clapped for a second, which is accurate. I mean, I didn't do it, don't clap. I mean, that's flattering. Thank you so much. I worked very hard to look up that story. That's massive. This is the quad kill, the fourscore of public health interventions. It is government-funded social workers doing compassionate labor, making meaningful changes in population health. That's incredible. We want this. But this is a future being actively denied us by the American healthcare model. Right? We live in a time of, I think, deep atomization and alienation, and so these kinds of self-harming conspiracy theories fill the void we feel between us and the world around us. I don't think I need to give you any examples, but it's only this unprofitable and tedious compassionate labor which makes a difference. And it'll just never be funded by Aetna, or by Cigna, or by Blue Cross Blue Shield, or by Emblem. Because if we leave it up to what we've got, vaccination counselors will never happen in the US because they're not profitable to fund. So these considerations of things which actually make us healthy are totally divorced from our model of health finance. And that's all to say, our model of health finance is deeply unhealthy. It's sick. And that's why I'm here, to get down with the sickness. I'm very disturbed. Get your laughs in now, it's a very sad speech. Let's get into it. Let's talk about healthcare. Thank you to book people, thank you to Melville House, thank you to all of you for being here. This is my first book, and frankly, I'm not really much of a writer, but I'm very proud of it, and I hope you find it useful. It's a toolkit for talking about health policy in the US. Instead of reading straight from the book and giving you 10 minutes on how Medicaid works, which is fascinating, but maybe not for this audience, I want to talk about some of the themes within the book. It's not all happy, but you probably already knew that. There's a lot of bummers in American healthcare, and there's a lot of tears in this book, but I try to align it with little glimmers of hope. Right? Because there's a vision in this book of a better world in which we can live free from the crippling fear of the betrayals of our bodies. we can stand together free and safe in our own flesh. And frankly, I believe in it. I believe we have the tools and resources to build this freedom. We just gotta demand it. We gotta demand it in opposition to the world we have now, a world that is not natural, but artificial. It is created by humans. And because it is created, it can be changed. But until it is changed, until we change it, ours is a birthright of continual exploitation. We are pumped for labor and drained of cash, and we suffer, and we are then punished for that suffering. We are punished for being hungry. We are punished for being sick, punished for being disabled, punished for being poor, punished for being black or brown, for being queer, for being pregnant, for being unlucky, for just being. And at the core of all that suffering and all that punishment sit two little truths. In this world, sickness makes you poor, and poorness makes you sick. So if you permit me, for the next half an hour, I want to talk about that relationship and how it's expressed through our healthcare and health finance models. I want to talk about three things: what we have, what we want, and what lies beyond. I want to talk about the overwhelming and numbing brutality of for-profit healthcare. I want to talk about the relatively benign structural changes that we demand instead, and then I want to talk about something bigger, which is that broader vision of the better world, the moral compulsion of health justice. That sound good by y'all? Fantastic, let's get into it. Let's have some fun. Let's start off with the fundamentals. It's fun for me. First up, nobody can afford to pay their medical costs by themselves. Medical care is extremely expensive. But generally speaking, not a lot of folks need it at the same time. In a given year, 50% of medical costs come from 5% of the population. That's a population which someday you will join, right? Eventually, your day of tragedy comes, and when it does, the medical costs will be enough to bury you. So we have the concept of insurance. Insurers pool together money from a lot of people to pay off medical costs for those who need it. And so the larger this pool of people, the wider it can spread costs, and the lower the per-person risk. Now in the US, we delegate the business of insurance to private insurance companies. Insurance companies charge us monthly premiums to build their risk pool. And like any company, their job is to make money. So here's where it gets dumb. If people use their insurance plans, the insurer loses money. So if an insurer has too many people who use their insurance plans to seek health care, or too few healthy people, or too many sick people, just one person with hemophilia, for example, can cost up to $1 million a year to insure, its per-person costs really increase. And so to compensate, it increases premiums. But when premiums go up, customers who can't afford them drop out. Unless they're sick, they can't afford not to have insurance. They stay on board, so per-person costs keep going up, so premiums keep going up. It builds this big, stupid, vicious cycle, this big Ouroboros of misery. Thus, an insurer wants as healthy or uneventful a risk pool as possible. It wants to find ways to kick out sick customers or coerce them into leaving the insurance pool. Maybe it drops coverage for the drugs sick people need. Maybe it cuts off access to providers who treat the sickest patients. Because insurance companies don't lose money when you get sick. Insurance companies lose money when you get sick and then use your insurance plan. And there's nothing they could do about it, even if they wanted to. Because if insurance companies were to offer the care people need where they need it, or at rates people could afford, people would buy insurance plans and use the insurance plans, and the insurer would lose money. And that's no way to run a business. You know, at some point along the line, I wonder what's even the point of blaming them. Blaming an insurance company for seeking profit, even though it hurts people, is like blaming a rabid dog for biting, or blaming a scorpion for stinging. This is just what companies do. And that's why healthcare doesn't belong in the hands of companies, because they just can't do the right thing. Instead, they've turned our bodies and our health into commodities. And this commodification of healthcare reduces health to a financial transaction or an investment vehicle instead of a connection or relationship between a person and their body and their doctor and their community. And it's perverted. We've mistaken the profit motives of corporations for healthcare. And the people who profit from that commodification have decided to shackle the well-being of children to whether or not their parents are lucky enough to have a benevolent employer who offers good benefits. And you know why they get away with it? Because insurance companies spend $50 million a year on lobbying. Pharma spends $70 million a year on lobbying. And until recently, nobody's had the guts to do anything about it. So that's one side of the coin. But it gets worse. It's too early in the talk for things not to get worse. Because the costs of healthcare keep increasing. Most of these cost increases occur because hospital CEOs, pharmaceutical companies, close personal friend Martin Shkreli keep finding ways to charge more money for the same services or rack up fees for other services, and no private insurer can stop them. Here's how it shakes out. Fundamentally, in the US healthcare market, all prices are fake. They're just totally fake. That means that, for example, in the US, average inpatient procedure costs cost 40% more than the same procedure performed in the same patient when performed in France. Or take MRIs. You all know what MRIs are? MRIs are just big fancy computers that print money. And in the US, an MRI scan costs 5 times more than the same machine performing the same scan when scanned in Australia. But it gets dumb closer to home. Sometimes MRI scans from the literal same machine at the literal same hospital can have a 7-fold cost variance, depending on which insurance company is footing the bill. Prices are entirely fake. But most frustratingly, consider the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, family health care, the kind of intimate health care you get from your family doctor or GP or primary care provider. It's high volume, it's low margin, and generally it's not super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So if you're a hospital CEO, it makes a hell of a lot more sense to push folks into inpatient care instead of wasting your time and minimizing your profit by letting them get cheap primary care outside the hospital. Or it makes even more sense to buy up all the cheap primary care clinics and either close them down or use them to charge inpatient rates, which is what they do. What's that mean? That means 58 million Americans have no access at all to primary care. So as you can see, these are the two fundamental but opposing truths to American healthcare. One, if you're an insurance company, it's just not profitable to insure people who are sick. Two, if you're a provider, like a big hospital, it is extremely profitable to charge sick people as much as possible, because what are they going to do about it? We built upon these jagged rocks the loathsome church of American healthcare, in which the question of who gets to receive healthcare and when, or rather, whose suffering matters to us, is rationed by profitability. Now, this whole scenario scares the bejesus out of everybody involved, particularly the insurance companies. Insurance companies are interested in finding ways to avoid paying these rising costs. Often that means just refusing to pay for claims they don't want to pay. But that's not enough to claw costs down. So we all got together, everybody in America, back in the 1970s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a libertarian way of saying people, pay more for the costs of their own healthcare. That's why your deductibles and your co-pays and your premiums go up every single year, to make sure you put more of your own skin in the game. We've decided to punish people with healthcare costs they can't afford under the guise of making healthcare a matter of personal responsibility. Also, healthcare CEOs and their friends can bring home millions and millions of dollars a year. But you know what's worse than that? It doesn't even work. I mean, it works for insurance companies who don't want to pay out claims, but it doesn't work for people. Because people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. They don't seek primary care, preventive care. Because we demand they bear the burden of costs they cannot afford, they just watch their bodies turn to time bombs until they have a heart attack at their jobs and leave their kids behind. But at the end of the day, costs keep increasing and quality of care stagnates for the most vulnerable among us. Our health finance model takes money from the poor and gives it to the wealthy. In 2014, it pushed 20 million people into poverty or extreme poverty, and 31 million people are still uninsured. The American model of health has failed. And there are consequences for this failure. Because among so-called developed countries, it is America that is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black, because black infants die at twice the rate of white infants. America is the most dangerous place to be pregnant, with the highest maternal mortality rate of any first world country, of which 60% are entirely clinically preventable. It is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. Last year, life expectancy at birth fell by 1/10 of a year, and across the 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you look at this data more closely. When you examine the numbers more closely, you realize all this danger only exists if you're poor. Because rich people are exempt. They have exempted themselves from these problems. Men born in the wealthiest fifth of Americans get to live 15 years longer than men born in the poorest fifth. On a woman, that gap is 10 years. We have made a choice. We have explicitly made a choice. By sustaining our private insurance model, we have chosen to let poor people die. We have chosen to let poor children die for entirely preventable reasons, all so that we can preserve and privilege private profit. And this is war. This is the terrible secret of American healthcare. This is the fundamental American illness. They are killing us and robbing our corpses to foot the bill. Now this big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked, it will collapse tomorrow. That is incontrovertible. It will collapse. So we demand something different. We demand a federal, universal, single payer. Single payer, pretty simple concept. It took me 10 minutes to explain private insurance to you, but I can explain single payer in one moderately long sentence. We pool together all the money we're currently spending on healthcare to create one publicly owned, publicly funded insurer, a single payer, with a mandate to cover in full all care for all people. Now that phrase, all care for all people, is clutch. We don't want Medicare as it exists today. Medicare has cost sharing, private carve-outs, not a perfect program. We demand an improved Medicare that guarantees comprehensive coverage, medical, dental, vision, long-term care, and mental health for all people in America, including non-citizens, that is free to use. Because everybody benefits when accessing care is easy. Delivering care, being a doctor, being a nurse, being a vaccine counselor, being a home health aide, that's complicated. The body is a big bag of unknowable goo, and relieving its misery is a challenging process. But paying for it isn't. Paying for it's pretty simple. People ask, how can we pay for this? We're already paying for it. We're just spending our money really, really, really stupidly. Practically every healthcare transaction in the US is partially subsidized by public money. By some measures, American public money pays for 2/3 of all healthcare costs in the US. A little less than half of that is actual Medicare, Medicaid, or VA spending. The rest is government subsidies to private companies. The remaining third is out-of-pocket costs, your premiums, deductibles, and copays, a kind of private tax you pay to your insurer, and you're being gouged. America is already spending the money required to fund single payer. We're going to spend $3.9 trundo this year on healthcare, and 1/3 of that, 1/3 of that, is spent on nothing more than waste. Half of that is payer-side waste, like admin costs and high prices. The other half is provider-side waste, like unnecessary or inefficient care. Now, take single payer. One paper claims that single payer plans in Congress right now would cost 10% less than what we're currently spending. We can spend 10% less to cover all people in full. Large healthcare corporations just jack up prices and jack up profits, and the insurance industry is unwilling and unable and inadequate to do anything about it, so it takes its cut and shovels the costs back upon you. And the bloat grows like a tumor, and we all suffer. And so the goal is to liberate people from medical costs, to cut out this thorny underbrush of middlemen, and to reallocate this spending to take care of everybody long term. Part of the reason costs are so high is because private insurers with their small customer bases just can't negotiate with big hospitals. Insurers need hospitals much more than hospitals need insurers. But right now, Medicare negotiates with half of 44 million people, so it gets better prices. Scale that idea up. Once Medicare for All negotiates on behalf of 330 million people, it can basically set fair prices for care while compensating providers justly. So these wildly inflated costs get their balloons popped and are brought back down to earth, and then we're playing on an even field. But even before that happens, we free up all the money associated with admin costs and marketing costs and profit within the private insurance market. And this optimization, this innovation, this disruption, it is Austin, opens up, in a conservative estimate, an additional $370 billion a year. 370 bundo, that's a big fucking chunk of change. What do we do with it? We use it to improve everyone's standard of living. We build or reopen primary care clinics in rural areas. We fund community health centers in poor neighborhoods. And most importantly, you return the money to the people who do the work. Take, for example, you all know home health aides? Or a sick parent, sick friend, sick kid, someone you love who's got a disability. A person can receive care in the hospital, but again, that's $2,000 a night, and it's kind of sterile. You're not at home. For a lot of folks, home is a better place to receive care. Home is where you live, where your stuff lives, where the dog lives, where the internet lives. And receiving home health from a home health aide costs only $120 a visit. So, fantastic. Everybody benefits, and we save money. Well, everybody benefits except for the home health aides themselves. Because for this humane and essential service, the 1.2 million home health aides in America are paid a nationwide average of only $11 an hour. I know it's much lower in Texas. So we can allocate this money to do what the private market won't do. Pay fair wages for essential care that helps everyone. I mean, think about it, right? What makes a real difference in health outcomes? Is it luxury hospital suites? Is it millionaire or multimillionaire surgeons? Is it $40,000 data packages for nerds to look at? Is it apps? No, of course not. They're just the people who get to bill the most. What makes a real difference is extra clinical care, compassionate labor, social workers, vaccine counselors, patient advocates, nurses. These are the folks who are chronically unrecognized and undervalued, and they're the primary drivers of population health. These are pretty basic ideas. These are pretty simple demands. We understand the social forces that make people healthy, and we understand the structural ones that make people sick. But in the multi-payer private model, nobody's investing in long-term health, nobody's investing in population health, nobody's investing in compassionate labor or paying these people fairly, and they never will. Because right now, your private insurer only bears the cost of you receiving care while they're insuring. Because you're gonna change insurers in the future, and eventually, God permitting, one day go on Medicare, they feel no pressure to provide you with care that makes you healthy now or helps you become healthier in the future. Let me put it another way. You know that if you're at home and your window breaks, the weather gets in. Right? And if the weather gets in, if it's really hot, if it's really cold, if it's raining, if it's a meteor shower, you get sick. And if you get sick, or if your kid gets sick, you got to go to the doctor. Well, if the local clinic was shut down, or it's booked solid, you got to go to the hospital. And if the hospital's far away, or you don't have a car, you got to get a ride, or you got to take the bus. And if you got to take the bus, you got to spend all fucking day dealing with the bus system. If you're going to spend all day dealing with the bus, you can't go to work. And if you can't go to work, you don't make any money. If you don't make any money, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the hospital. The answer begins with giving people what they need to fix the goddamn window. But there are no private actors in the American model who will consider bearing responsibility for fixing these problems on their own. Right? The only innovations of the private insurance industry are ones created to solve problems created by the private insurance industry. They are incapable of addressing the real and foundational problems of healthcare, of fixing the broken windows, of reopening the 18 rural hospitals that have closed in Texas in the past 5 years, of repairing the PVC septic tanks in South Carolina that have ruptured and brought hookworm back to the state, in the exact same way that a billionaire is incapable of lessening income inequality, or that a cop is incapable of shrinking the prison industrial complex. They cannot fix this injustice because they've been constructed by that injustice. They cannot solve these problems because they existentially cannot conceive of them as problems in the first place. But we can, and we do. And so it makes perfect sense that the same actor who suffers when people don't get care should be the actor who pays for that care in the first place. Because once that federal actor, once that single payer bears the costs of providing care and the costs of what happens when care is not provided, once we force it to confront the rampant suffering of all its people, it can finally be used as a tool for realizing health justice. If your people are getting sick because they don't have a place to live, or where they live is unsafe, it's full of mold, it's full of water, it's flammable, then housing is healthcare. And you build safe social housing to bring healthcare costs down. If your people are getting sick because they don't have access to healthy food to eat, and so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you provide them with affordable or free food options and the time, space, and materials with which to prepare them to bring healthcare costs down. And if your people are suffering because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare, and you build full-cycle addiction treatment programs to bring healthcare costs down. Because single payer is fantastic, but it is not the goal. Single payer is only the tool. Health justice, health equity is the goal. And when we fight for health justice, we all fight side by side because economic justice is health justice. Environmental justice is health justice. Reproductive justice for those who don't want to reproduce and those who do. That is health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for the lives of immigrants, justice for people in prison, and the well-being of all people, regardless of age, gender, race, or creed, that is health justice. We have inherited a world in which your permission to receive healthcare, your permission to be safe in your own goddamn body, is dependent upon how much a corporation can extract a profit from it. And thus, we have permitted in our country utter desolation. And I want to talk about the desolation now. Over the course of researching this book, I took to the road. Every morning I'd wake up, eat a banana, drive 6 hours in my 2002 Honda CR-V, give a speech, and then talk to people. People who would tell me the worst things that have happened to them. I kind of became a library of human misery. And so I want to share 3 stories with you, one long, one short, one medium, to contextualize the fight for healthcare and the movement for health justice. The first takes place in Houston. One thing I haven't discussed much is mental health. And you can't talk about mental health in Houston without talking about the Harris County Jail. Now it's the largest provider of mental health services in all of Texas, which is a fine observation, but it doesn't really investigate the relationship between mental health and prison. Let's talk about that. In Houston, people who are arrested and suspected of having mental health issues are held in these dark, dank, dungeon-esque cells in the Harris County Courthouse. You would not know these cells existed unless you were looking for them. So if you're a person with a mental illness who's been locked up for several days for things like trespassing or disorderly conduct, what do? You haven't had your meds while you've been locked up, and so you got 2 choices. 1, plead guilty, and you might get out on time served. 2, fight it, and you're looking at more time locked up without your meds. And this is if you're lucky enough to pass as functioning normally. If you're in the middle of a serious episode, things get worse. Then you're held for up to 30 days until the county gives you a session with a psychiatrist. People are held in the hospital wing of the prison or the prison wing of the hospital. There's this concept of the prison to hospital pipeline, which comes up when you discuss mental health in jail. But it's not a pipeline. Pipelines are unidirectional. They go in one direction. It's more like a pinball machine. These giant invisible flippers bounce people around from jail to hospital, and hospital to jail to hospital, and back and forth. And at some point, there is no functional difference between the 2. We refuse to care for people, and so they become sick. We make them sick. And if you're the wrong kind of sick, or if you're the wrong kind of person, we delegate your care to private prisons. It's technically not a crime to be poor. It's technically not a crime to be sick. It's technically not a crime to be black or brown. Once you fall into the intersections, the rules change on you. If you're a poor single mother of color, for example, you have virtually no right to privacy. If you're in Section 8 housing, a state agent comes to your apartment twice a month and counts the shoes on your shoe rack. If they find too many shoes, or if you're a single mother and they find a man's shoes, you can lose your benefits. If you're disabled and on Medicaid, every month or twice a month, a nurse comes to your house to check if you're still disabled or if you're faking it. a deeply humiliating process. You can't make more than $2,000 a year. If you're a Medicaid recipient in a work requirement state, every month you gotta wait in line for hours at an understaffed office to prove that you're employed, time you can't spend at work. And so these processes drive people into the hospital, or into the streets, or into jail. And so long as we use prison to hide those who have been made undesirable by their healthcare needs, healthcare and prison are inseparable. So while the idea that prisons are the largest providers of mental health care in the US is a well-intentioned and technically correct point, it's wrong. Because no prisoner will ever receive the care, support, or resources they need to handle whatever's fucking with them. And no prisoner will ever be saved from the inevitable return trip once they get out and remain sick and get arrested again, because prisons are not hospitals. No one receives care in a prison. They are warehouses for the mentally ill. They are storage units for the unwanted. That's Houston. Another story I want to tell is about birth and death in Memphis, Tennessee. At the turn of the century in Memphis, 20 black children died for every 1,000 live births. 20. That is an incomprehensibly high number. There is no peer in any first or second world country for 20 black children dying for every 1,000 live births. Why did they die? Because Memphis is home to 2 nuclear waste disposal facilities pushed up against poor black neighborhoods. But it keeps going. It always keeps going. Where do poor babies go when they die? In Memphis, they go to Babyland, a corner of the public cemetery. They are put to rest in cramped rows beneath the earth, in unmarked graves a block and a half away from a Walmart. Or at least they were, until recently. Because in 2014, Babyland filled up. Poor black children in Memphis die in such volume. America is killing the poor black children of Memphis by poisoning their mothers and poisoning their homes so effectively that we have run out of room to hide our shame. We have run out of room to bury the bodies. And finally, I want to talk about Scott County. You might know Scott County, Indiana, is one of the few places in the US with a new population-wide epidemic of HIV/AIDS. And we understand the causes. 1, pharma companies invented tamper-resistant pills which can't be crushed and snorted. This does nothing to prevent misuse, but you get a new patent, so it's very profitable. If you're a person battling addiction, not being able to snort doesn't keep you from using. You just turn to heroin or turn to fentanyl. 2, then Governor Mike Pence shut down needle exchange programs in the state. Needle drugs are illegal, and so therefore they're for criminals, and why should we spend money on criminal health care? 3, Indiana gutted, shut down, or cut funding for community clinics and places like Planned Parenthood. And so here's the breaks. If you're a person in Indiana battling OUD, opioid use disorder, tamper-resistant pills mean you turn to needles. Except now you can't find a clean needle because the exchange is shut down. And the other clinics you used to go to are unavailable as well. What's predictable? More people get needle diseases like HIV, AIDS, and Hep C. But that's not where the story ends. These people have families, they have communities. Now they have HIV, AIDS, or they have Hep, or they're in jail, and their families miss them. These people have been left behind. Indiana also has a very low property tax cap, which limits school funding, and it has a robust school voucher program. Better off families who don't want their kids to attend school with the children of the left behind send their kids, and therefore their tax dollars, elsewhere. And so Scott County schools got less and less money, and more kids per capita with families going through the shit. That means fewer teachers, less food, and no mental health or guidance programs. Spoke with a guy who said you could spot a kid going through hell from a mile away. A kid with a parent in the system, a kid without support, a child unmoored in the world, but there was nothing he could do to help. There was just no funding. There was no funding for breakfast. There was no funding for therapy. There was no funding for daycare. There just weren't any resources for the children of the left behind, and so Scott County saw an increase in child suicides. all these things have causes. And all these causes are cyclical. And they have happened forever, and they will continue to happen so long as we tolerate the idea that the body is a commodity. And if that commodity is not valuable, if there is no profit in the care of sick people, or homeless people, or people battling addiction, people with disabilities, or poor people, or pregnant people, or trans people, or women, or black people, or brown people, then there is always the private prison system ready to receive them for profit. And this servitude continues in death because the organs of the poor are transplanted. They are ripped and sold to the bodies of the wealthy. There is no end to the body horror of capitalism. There is no line too far for the commodification of the body. I say these awful things not to pornographize suffering, but because these are the stakes of the fight for health justice. And so I want to be explicit. Insurance is not enough. Our goal is not simply insurance, but emancipation. We must put those who have been most harmed at the front of the line. We must walk together every goddamn step of the way. We must never compromise until all have been liberated. Why is it that some have adequate health care and others do not? Why is it that some have adequate housing, some have adequate food, adequate income, adequate safety and dignity and humanity, while others do not? Why is it that some get to live freely while others are compelled to fear their own bodies? Our health is apportioned to us along the lines of structural poverty and structural racism. Our American body has been poisoned by the wicked snakes of racial and economic and patriarchal domination. And so when we attack, we must attack the beating heart of capitalist exploitation itself. And these are problems that private insurance cannot fix and will not fix, and in some cases has caused. These are problems which can only be addressed with the full force of all America's people, our bodies together forming the shape of our government, armed with a single-payer healthcare system. Single-payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. There is some good news. We do know what has worked. We stand on the shoulders of hundreds of thousands of nurses, of tens of thousands of doctors, and the legacy of grassroots movements like ADAPT and ACT UP, who have fought against impossible odds and won and won and won again. In San Antonio, the movement for paid sick leave turned out 144,000 signatures, which is the largest movement in years, if not decades, in that city. In Maine, the Maine People's Alliance won a minimum wage expansion campaign and then turned that successfully into a Medicaid expansion campaign, winning 57% of the ballot box. In Idaho, 3 friends bought a camper van, painted it green, and drove around the state to build a movement to expand Medicaid. And that movement won 61% of the vote, even as a Dem candidate for governor lost by 22 points. There was no blue wave. It was a people's movement. It turns out, if we give people something material, they will fight to keep it. If we fight with people today, they will fight with us tomorrow. We build solidarity so we can build power. Our goal is not to build a single popular movement, I don't think. It is to stitch together a popular movement. A big, messy quilt of movements for health justice, spanning the country from coast to coast and plains to gulf. And through these popular, massive mobilizations, and only through these massive popular mobilizations, this is a fight we will win. This is not a radical proposition among the folks it affects. People generally like single payer. They like it a lot. The more they hear about it, the more they like it. We are simply discussing a basic principle of fairness. And so, I offer you my profession of faith. I believe, beyond any doubt, that single payer is demonstrably sound and eminently feasible. I believe a properly ambitious and well-structured single-payer program will do more than any other American social program of this generation to soothe the burns, to resuscitate the spirit, and to nourish the moral will of the American people. I believe it will loosen the loathsome manacles of American health finance and its theft of our bodily autonomy. I believe this nation owes its people, whose labor has created its rich banquet, the safety and agency of healthcare. I believe this healthcare is greater in scope than that which happens upon an operating table. I believe that housing and food and income and more, the components of basic human dignity, are healthcare. And I believe our work is that of striving towards justice for all people. And I therefore believe, and I have to believe, that single-payer healthcare is our moral imperative. Single-payer is our tool. Single-payer is our weapon. Single-payer is our first step. But single-payer on its own is not the goal. I have seen, as you have seen, such naked suffering inflicted in my American name. I have seen families ripped apart by the unrepentant, unyielding bloodlust of capitalism. I have seen people torn limb from limb in the service of extracting profit, and this is intolerable to me. And so I say, enough. Not in my name may this America persist. May we root ourselves not in fear, but in love. Love for those who suffer around us. And from that love, may we cultivate the righteous fury by which this cruel machine can and will be destroyed. My friends, single-payer is moral. Single-payer is necessary. And single-payer is, I swear to you it is, achievable. Solidarity now, solidarity forever. Thank you very much. I don't know how much time I got. Yeah, it's when we hop into Q&A. Who has a great Q that I can name? You got a Q?
Yes, I got a Q. So what do you think is the best way to advocate for single payer?
I don't think I can tell you that because the way you do it is local, right? I live in Brooklyn. I hate to be a carpetbagger, right? The worst thing in the world is when Brooklynites come to Austin and tell you to do things. I think that DSA is a great place to start. I don't know if you're a member of them or not. My advice of what I've seen work elsewhere is win the thing you can win locally, and then from that victory build more things, right? But what that victory looks like, I can't tell you the shape and contours of. So find a weak point you can hit the button on, and smash that MF button and use it to generate a future victory. That's all we can do, right? Like, we're not going to win a national victory right now. We got to win the local ones first, and from that, build the scaffolding by which we demand the things that we want on the national level. So win what you can here. If you're not involved in an organization, I know DSA is a great one, and I am a member of the DSA, so of course it's a little bit of homerism. But get involved, show up, get your butt in the seat, and do the work. That's your question? Cool. Any single-payer health finance questions? Because that's fun for me. I've got some answers I can give to questions someone's asking. Like, what to do. What's up?
What about my experimental mental health treatments? Will those be covered under a single payer?
Are they covered right now? Well, that is a good question, right? Because here's a multi-million-dollar dingus that I get for my Zongler condition, which is serious. People deserve to get the care that they need. But right now, we are rationing that care by profitability. You only get that care if you can afford to pay out of pocket for it. If there is a significant supply side restriction on more of these treatments, if they require crystals from the moon or whatever, and you can't build more of them, I think it's better to ration it by medical necessity, who needs it the most, than by who can afford to pay for it the most. So.
Will providers be paid less under single payer?
That depends. Providers come in two flavors with two flavors underneath that. You've got massive corporate hospitals, and you've got hospitals and corporations, and you've got doctors, right? Corporations are the ones that commit the most medical fraud in the U.S. A small sliver of medical fraud is performed by the patient. Most of it is by hospitals, insurance companies, and other healthcare corporations, private equity companies. Of course, they got their hands in that. They will probably see a reduction in profit, but they will get the money they need to keep the doors open and do the work. So they'll complain that they can't afford to keep the doors open by receiving only $200 million in profit instead of $400 million in profit, but they'll be complaining about that no matter what kind of health reform is on the table. And you got doctors. Doctors come in a couple of different flavors. Let's say for now, the two specialties are specialists and PCPs, general practitioners. You've got a graph that looks like this. As far as salary goes, it looks like this, as far as number of doctors. A bunch of doctors are making very little money, talking 80 to 120K, and the small number of doctors are getting tens of millions of dollars. These folks will probably see a reduction in how much they're getting paid because it's coming at the expense of the people down here. It's in the book, which, by the way, you should buy, Health Justice Now, single family available now from Melville House at Book People. There's a committee the AMA runs which helps set prices in the U.S., which is a bizarre amount of private leverage over public costs. But it is staffed by a council of doctors, and they have one primary care provider on that council to represent all primary care, and 5 hand surgeons to represent each of the 5 fingers or whatever. It's skewed in the favor of the specialists. So they've been tilting prices in the favor of specialists for a very long time. So I think there's a parallel fight here that goes along with this. Right now, if you're going to med school, well, one, you're probably born rich because med school costs $300,000, and only the children of doctors can afford to become doctors themselves, which is fundamentally unjust. That is how you build a grossly non-representative body of doctors. But 2, you're in med school and you're looking at how much jobs pay, and you're seeing hand surgeon, brain surgeon, whatever, $10 million a year, and you're saying, shit, I got $300K in student loans, I should go be a hand surgeon. General practitioner, primary care provider, I can't afford to live off that. I'm going to go into specialty care, which results in a pretty big shortage of primary care providers in the U.S. Actually, it's funny. In the early 90s, there was a big fear we'd have too many primary care providers, and they would all go broke from there being a big glut of PCPs. So the Clinton administration put together a bunch of policies to throttle the quantity of PCPs that we send from med school. There was a New Yorker comic of a bunch of doctors waiting in a bread line, which was very charming. So the shortage of PCPs is like an invented artificial problem. We've caused this problem. We can uncause it. But I think that a parallel fight for single payer to achieve health equity in the U.S. is making med school training free. Med school, nursing school, home health aid school, these things are civil services. Let's treat them as such and subsidize their costs. That way, it becomes less of a problem if a doctor receives less money than what they would receive now because they're not paying off $300K plus interest to go to med school. There is also an offsetting thing. Right now, a doctor spends 60% of their time dealing with billing. And you don't get paid to do with billing. So you see patients less than half the time, then you go into your back room and poke the computer, trying to figure out which insurance company, which plan or whatever, do that kind of shit. Under single payer, it is basically a one-button model. So you free up you free up most of your day to actually see patients. And if you're getting paid per patient, or if you're getting paid a bundle fee or a per capita fee, you actually can make more money or the same amount of money because you have more time to actually do your work and less time spent on billing. Same with nurses. Nurses spend 40% of their time dealing with insurance companies. So there's like this tamped down ability to work because of private insurance that is suddenly lifted up, and you can see more patients and make more money. The actual fee structure of how much will a given procedure cost, estimates are it'll be more than Medicare now, but less than private insurance. That's because private insurance is getting screwed and pays between 3 and 7 times what Medicare pays. So you can some doctors will make a lot more money, some doctors will make less. More of the people up here will make less money, and more of the doctors down here will make more. But you can't really pick a singular entity and estimate from there. Can I answer your question?
Kinda, yeah.
Cool. What's up?
When it comes to the federal actor bearing the costs of healthcare, leading to a situation in which they're incentivized to invest in other things that make the view of healthcare more comprehensive, housing, food, the different dimensions of your argument. What systems have you seen around the world where that dynamic actually takes place and doesn't instead become a justification for austerity against the medical system?
We're actually seeing it right now in the U.S. in the private sector, which is buck wild. Private hospitals, and so the goal is never to have this thing be a private model, but even private companies have taken this into their own hands. University of Illinois at Chicago Hospital, and a big hospital chain in Orlando, I forgot the name of it, let's say Orange Hospital, have big problems with the term they use, frequent flyers. People who are chronically unhomed, who show up in the hospital over and over and over again. It's snowing, it's too hot, whatever. And that costs a lot of money. It costs money to provide hospital care. And it's taking up a hospital bed, which could go to a more profitable patient. So these hospitals both have begun building housing for these patients, which they give to them for free. They build a housing unit and say, we'll have a live-in social worker, and this person will help take care of your needs. And as a result, the hospital saves a shit ton of money from that upfront cost. costs. So because these pressures exist, these pressures exist, but they're not being used anywhere. They're being diffused into the private sector. And I don't want the model of housing as healthcare to be relegated to what private companies see as being profitable for a handful of patients. I think these pressures can be used in the U.S. model. You see that a little bit, even in Medicaid in the U.S. New York Medicaid, for example, has a massive grant to build housing, safe housing, especially in New York City, where you've got a massive housing shortage. That happens also in California, which has a robust Medicaid program. Like Medicaid is, at the same time, the best thing in the U.S., other than pro wrestling. And one of the worst things in the U.S., depending on what state you're in. When Medicaid gets it right, they get it so fucking right. So Medicaid does invest in all these social determinants of health, because they have to, because their budget's on the line. Because they have to take care of you regardless of whether you got a house or not. So they're interested in getting you the house, getting you food. They build all these programs out. So I don't think we need to look abroad to see this kind of movement happening. It's already happening in the U.S. It's just being diffused across the Medicaid sector and the private sector. So I do believe that it does create that leverage, and that leverage has been shown to be usable, and because it is a public model, we have the leverage to really jump down upon that lever and send it off into the stratosphere. So,
If we move to single payer, how do you think that will change the landscape of healthcare administration, from a jobs perspective?
you mean like insurance jobs?
Insurance jobs, healthcare provider jobs, just administrative jobs, non-clinical.
Sure. So there's encompasses, the question was how will healthcare admin jobs be changed under single payer? So there's a bunch of different subcategories of admin jobs, right? I can't go through and think of them all right now, but I can give an answer that I think might explain part of that. One, there will still be a need for a significant number of healthcare admin jobs, even under single payer, right? Hospitals still got to run. There still is a single insurer. It's got to run. Got to have the various tubes and technologies required to make a giant public insurance company operate. But a lot of folks might no longer see a role or not have a job in a public insurance model. So here's, I think, a glimmer of hope for that. Most people whose jobs are safe in insurance companies work in the first half. They do the tubes and technology part, or they know the EMRs and billing models, which will probably still exist under a single payer. Those jobs are probably likely to stay around for a while longer. If not, there's always the $5 billion both Jayapal and Sanders have in their bills to do retraining. But most folks in healthcare admin or in the office side jobs don't have those jobs. They work in customer service, customer support, or billing management. They're phone workers, right? And so their job is to either talk to patients and say what the minimum amount of care they're required to provide is if they work on the insurance side, or argue between a nurse in an insurance company and a nurse in a hospital about how little care the hospital is required to provide to save money, kind of this back and forth. Fundamentally, your job is to, in these sectors, is to find out how little care someone around you is required, how little care you're required to give somebody around you, which is kind of disheartening. Now, there's a bunch of jobs, people don't talk about this, but there's a bunch of jobs a single payer is forced to consider and create in its development of long-term population health programs. Vaccine counselors, for example, are a very small example of the kinds of jobs a single payer is incentivized to begin creating to keep people healthy long-term. But there's 24 more jobs like that. One is a model of social work called the medical legal partnership, which I'm particularly fond of. Here's an example. It's a Medicaid clinic that's run out of Boston, because occasionally a good thing comes from Boston. And it's a clinic which has 2 arms. And here's a real story that I like. A person walks in, and they've got their little kid, and they go to the front desk, and the desk has a social worker. And they say, hey, my kid has asthma, my kid is 4, 4 is too young for asthma, what do I do? Social worker does a single intake, which is important, because you want to have as few hands involved in an intake process as possible. And they say, oh, you probably need clinical care, let's take you down to the first wing, and here's a doctor, here's a nurse, we'll get you albuterol or whatever, get clinical care, fantastic. The social worker knows that asthma in children is often caused by external home factors. So they ask, well, what's your home like? The patient says, well, we live in the slums of Boston. There's water in the ceiling, there's mold in the walls, my landlord's a piece of shit, I can't do anything about it. Social worker says, that's where you're wrong, and brings them down to a second room where there's a lawyer, possibly a very charming lawyer who I'm going to marry someday. That's how I've heard the story. Who says, oh no, you have protections against this. It turns out we all have a lot of civic protections against the things that make us sick, you'll need access to those protections if you can afford to hire a lawyer or if you have the literacy and fluency and whatever to do it yourself. And no one has that. There's all these protections only exist for the wealthy. So this charming law student says, here's a letter threatening legal action against your landlord. We'll mail it in for you on our fancy letterhead, and we'll check back in 30 days. What do you know? The landlord fixed up the walls and fixed up the ceiling in the apartment. So this entire model is cool, but it hinges upon that social worker taking the person in and saying, okay, what are all the kinds of care I can possibly give you? What's the housing care, the food care, the legal care? What can I find? It is the, I would say, Matthew Lesko model of health. That's right, Rory. You guys know Matthew Lesko? If you watch TV late at night in the 90s, Matthew Lesko was a dude who wore a Riddler suit and would sell you a workbook of all the money the government owes you. Free money from the government. This dude's entire John was finding all the things you are entitled to, all that money you can find on the couch cushions, and getting it to you because you deserve it and he gets paid. And that is like a good model of healthcare social work. What are all the things you deserve? What are all the things you were entitled to? How do we get those in place? And that requires a lot of labor. Now, it turns out you're like people, if you're laying off a bunch of folks who work in call centers, who work with patients every day and try to find the least amount of care they're required to give them, isn't that a natural fit to kind of invert that and have them operate in the same function, but now finding the care, as much care as they can for a bunch of people? There's like a bunch of jobs we need to build. We have a shortage of healthcare providers in the US, not enough folks who are doing the important long-term work. And I think a single payer is uniquely poised to create a lot of jobs. But for those whom fall through the cracks, and there will be some folks fall through the cracks, that's how we have and must insist upon robust long-term job training programs and relocation programs in single-payer bills. Or nationalize the insurance companies and make sure everybody gets their share. I'm fine with that. Are we getting cut? All right. I'm going to answer one more question that I thought of. What about pharma? What about R&D? Because I hear this every single time. What about pharma and the R&D budgets? The question usually goes like, but pharma says if we have single payer, we'll lose all their money, and then they can't do R&D, we won't get new drugs, cancer will never get cured, etc. To which the answer is, and this, sorry to be like jokey, because this is a serious one, the primary innovation of pharma in the past 20 years has been the opioid epidemic. They took a drug that already existed, they added one more molecule or whatever, got a new patent, and sold it with millions and millions of dollars in marketing costs, and destroyed an entire generation of Americans. 18 people a day die from opioid disorder. That's the primary innovation of pharma. Right now, they spend, I think, 20% more on marketing costs than they do R&D costs. Marketing is literally the primary function of pharma companies. And what's more than that, they're not even doing any good R&D. All the good breakthrough drugs come from public research. Some person, some kid, goes to grad school, works in a thesis for 15 years, or I don't go to grad school. Dropped out. Figuring out like which chemical goes on which one, and they put together in the thesis, and they're very happy, and then immediately UT sells that to Pfizer for $100 million for a new gym or whatever. It's a packaged process that has partnership. So all this research that actually happens, makes a difference, comes from students, comes from public universities. Pharma does R&D, but it's more like we have a right-hand molecule and a left-hand molecule. What could this be used for? Let's try it to 20 different things and pass it out that way. They're not doing like the groundbreaking research we need to actually make a difference in things like cancer or diabetes. Which I think is a call to nationalize the pharma industry or build drugs, generic ones, locally. Like we can build insulin domestically and give it away free and save us money in the long-term process. But pharma can sell the same drug in the U.S. for $80,000, Hep C drug, for $80,000 to Medicaid, $24,800 to the Coast Guard, and $8 in India, making a profit in all three sectors. Like this idea that we subsidize R&D is horseshit in three different levels. So that answers the question nobody asked. With that, I need two things. One, please buy the book. If you already bought the book, I'm sure your dad or your mom or your partner would love the book. I'll be here to sign it. And two, I help run a pro wrestling league in town. We have a show on Saturday. So if you love razzle, dazzle, bedazzle, bedazzling, if you love slams, jams, and thrams, come see Party World Wrestling at 10615 Metric Boulevard, that is 4th Tap Brewing Co-op, this Saturday at 7:30 p.m. Be there or don't. That's right.